these classes will be special classes on Unacademy platform. You can watch it in the app or in the website, whichever your convenience is fine. So let's go ahead with today. Hello guys, this is Dr Ranjith again, your pathology educator at Unacademy. So today we are going to see a series of cases from today onwards for pathology postgraduates. We have been discussing the cervix for the pathology postgraduates in the special classes. If you're a postgraduate in pathology or you're going to join your first year, I'd urge you to just watch the videos. We are going system-wise discussion. We're done with endometrium and we are on the verge of cervix. So I just want to mix up these cases and put it as short videos so that it will be helpful for you guys to recap whatever we have studied there, apply that and come to a diagnosis, right? And in this case, it's a very simple case which came from an I think 40+-year-old person, cervical lesion, right? Clinically, it was diagnosed with cervical polyp, and we saw in microscopy, like generally it won't be the same. So one thing I want you to urge for whenever you have a history of or suggestion of a polyp, while crossing, it's very important. If you have a polypoidal tissue, every time when you have a polyp, let it be cervix or your colon or whatever organ it is, I want you to do a crossing from the stalk to the base. Everything, it should be crossed throughout. I would prefer that don't cut from the base, because when you cut from the base, it kind of get a little bit disoriented. If it's a tiny polyp, if it's visible like a polyp, I would use to make generally a flat surface. Keep your palm on the top of the polyp and cut with a single cut, right? And it should come from the top till bottom. And one important suggestion is I want you to use a sharp knife. The reason why I'm saying sharp knife is when you use a blunt knife, this overlying epithelium might get injured, because the entire diagnosis of a polyp, if it is an epithelial polyp, rests on the epithelial architecture, right? So once it gets injured, once it gets damaged, it might be sometimes a little bit difficult. So to avoid the difficulty, use a sharp one, a flat surface, press on the top and just give a single cut, right? And you have to embed the polyp everything, especially if it is in a colon, and every organ, embed the entire polyp. Make sure the stalk is perfect, and if you can identify a polyp, that will be the great. If it's not a polypoidal tissue, like usual, embed everything and see what's there in microscopic, right? And then we went ahead with this case. This was the microscopic finding of the lesion, right? With this is maybe a 10x picture. What you can see here is, apart from the blood and the exudative features here, what I can see here is the glandular architecture, right? It's a cervical region. This amount of glandular architecture looks a bit scary at the first instance. But one thing you can see is you can see a little bit of mucin vacuoles here. So I would say that maturation is still maintained, though it's a lower power. We have to go and look at the higher power to give and comment more about it, right? So in this power, I do have an epithelium which is more or less normal in this power, and in the stroma I do have lots of glands. Maybe a little bit of hyperchromasia is there here. Let's see what is in the stroma and going to a higher power, right? So the same lesion, when you go to a higher power, look at this. As I said that it has preserved nucleus. The nuclear is not so bad. I can see a little bit of proliferation here and there, but it's not so obvious. Mucin is retained. There is not much of squamous metaplasia, right? The only thing which is contemplating for me is my stromal lesion. Stroma is a bit less here, though I do see the cervical stroma, and the cervical stroma only, not the endometrial stroma, and there are a few inflammatory cells here and there. Okay. Again, when you go to a little bit of higher power, the nucleus is very blunt. See, one thing always keep here, if you're going to sign out a malignancy, make sure the nuclear architecture is not good. If I have a super bland nucleus like this, a single layer with maturation with mucin, most of the mucins are in the subvacuolar space, right? There's actually a diagnostic clue for whatever we're going to see. I'll show you all the points what WHO says. Every point fits into the case. It's a perfectly normal nucleus. Never ever think of a malignancy. I'm just going back when you saw we had lots of crowded glands. That is not going to make my diagnosis different. I'm going to go with nuclear architecture. Though in low power, I had a slight hint, could it be malignant, which is totally thrashed when I go to a higher power, maybe 20x or 40x, right? So it's not a malignant epithelial. The cytology is not at all malignant. I have so no mitosis, right? So definitely a benign lesion of the cervix, which is of the glandular etiology. Again, I'm stressing you to go back to listen to the lecture on cervix, which we had discussed about the benign variations of cervix. There are lots of benign mimics. You have to know them, you have to diagnose them, you have to rightly accurate them, because there is something called mesonephric metaplasia. There's mesonephric gland, ectopic prostatic tissue, all of them is going to mimic benign glandular lesions of cervix, right? I want you to go through it. When you're reporting something, I want you to write the perfect terminology as per mentioned in WHO. And this one we did report as in microglandular hyperplasia, right? So let's go to WHO. What WHO talks about microglandular hyperplasia? MGH stands for microglandular hyperplasia. They show closely packed glands. That's what we saw, right? And often as to with reserve cell hyperplasia, we didn't see reserve cell hyperplasia in this patient. So that is not must for me to make a diagnosis of reserve cell hyperplasia. If it's reserve cell hyperplasia is there, I'm going to be much more comfortable, that's all. This also we have talked when we have discussed about squamous metaplasia of cervix. So when I have a reserve cell hyperplasia that's a layer beneath my columnar layer, then I'm going to be more comfortable, that's all. If it's not there, ignore it, completely fine. The glands will have columnar to cuboidal cells, yes. We did have mucin, and often it will be subnuclear, that's what I said. Everything what you saw in the image was classical. Subnuclear vacuoles looking like a signet ring. It's not a signet ring, it's just a columnar epithelium, right? Nuclear small, yes, absolutely small, regular, no ATP, nothing. The mitotic index is going to be extremely low. The case what we saw here was not a differential diagnosis of a carcinoma. It's a straightforward case of microglandular hyperplasia. Sometimes I might feel difficulty in diagnosing whether it's microglandular hyperplasia or a malignancy. Whenever my microglandular hyperplasia is solid, I had shared a case of solid microglandular hyperplasia in the Telegram group for postgraduates, right? If you get time, do join the Telegram group, and I want you to just go through cases. We'll keep discussing cases on and off, and that will again hone our diagnostic skills, that's all. The solid pattern is a bit tricky. A reticular pattern, trabecular pattern is fine. It looks more or less the same. It looks like a benign lesion. When it's completely solid, the problem is, as I said, that it looks like signet ring cells, right? So when everything merges, it looks like a solid lesion of signet ring morphology. But still, even in those cases, there'll be no atypia, no mitotic figure, right? And there's a florid microglandular hyperplasia. The florid lesions goes way deep in the stroma. So again, when you have a very deep lesion in the stroma, made of tightly packed glands or solid glands, you might be hesitant to call it an you might think of an carcinoma, right? Always keep in mind that microglandular hyperplasia is a common lesion in the cervix, and it should always should be differentiated from a carcinoma, right? I don't want an IHC as such to diagnose a microglandular hyperplasia. WHO clearly mentions that IHC immunohistochemistry is unnecessary to diagnose microglandular hyperplasia. But if you have a differential diagnosis, I would say please apply it. See, the book, whatever it says, it need not be taken as a gold standard always, because I might feel it ugly, right? If you feel something is like pleomorphism there, please go ahead with your immunohistochemistry, right? Judicially use it, don't use it for every case. Judicially use it and say and be clear that what other lesions I'm going to use it for differential diagnosis. Two differential diagnoses, one is endocervical adenocarcinoma and endometrial adenocarcinoma, right? The IHCs for the glands here will be positive for ER and cyclin D1. It will be negative for P16, Vimentin and CEA. Right? It will be negative for all these three. That helps me to rule out both my close mimickers of endometrial as well as endocervical adenocarcinoma, right? Again, only when you have doubt, you can go ahead with it. Though WHO says it's unnecessary, it's fine. It's on a case-to-case basis, right? The experience, what you have seen. Once the first time, you might find it difficult to call it a microglandular hyperplasia. Apply IHC. It's a learning procedure. Make sure, yes, this is how it's going to use. Register that in your head, and definitely next time when you see a case, you can be much more confident. That's it. So first time, it's completely fine. You're trying a new diagnosis. I want you to be very careful, fine? And Ki67 definitely, since mitotic index is low, it will be less than 10%, right? So we did discuss about one case today about microglandular hyperplasia. We'll have a little bit more case nuggets in the next 10 days. During the end of every month, we'll try to consolidate whatever we have seen in that month for postgraduate teaching in the Unacademy app. You can follow me in the Unacademy app, and you'll have a notification of all the postgraduate classes, and I hope it will be useful as well. The reason why microglandular hyperplasia most stressed is it's a completely benign lesion and has zero malignant potential. So it's a relief for the patient as well as the gynecologist, right? So this has to be mentioned. It's microglandular hyperplasia. Maybe if you feel like, put a note that it's a completely benign lesion with no malignant potential. It makes it more complete. That's it, fine? As I said, you can follow on the Unacademy app. You can follow my profile. You will get notification whenever there's a PG program. I'll keep updating whenever I have a PG program or any new cases, both on my Telegram and the WhatsApp groups. So let's see. We'll spend more time into postgraduate teaching. we'll hone my skills, my diagnostics, as well as we'll grow together. Fine. Thank you for your time, for watching. And as I said that all the classes which will be conducted for postgraduates will be special classes. I'll be free of cost. Fine. Let's learn together. See you soon in another case nuggets. Till then, bye bye from Dr. Ranjith. Bye bye.